served on the board of directors for Baylor Scott and White, the largest healthcare system in the state of Texas, led at the time by our good friend Joel Allison, who is another towering figure in healthcare in the state of Texas, and a fantastic and noble man. You started down the path of getting some complex questions at the board, and that led to your taking on a new role with regard to ethics. Can you talk about the evolution of that role and some of the questions you had to deal with?
Yeah, thank you very much for that. So Baylor Scott and White started as what we think of as Baylor University Medical Center. It was originally Baylor Memorial Sanatorium, I think was the first name, George W. Truett. Back in the early part of the 1900s, well-known pastor of First Baptist Church, Dallas, who said, "Is it not now time that there be a great humanitarian hospital?" And here's the point: one to which men of all creeds and none may come with equal confidence. And from then till now, that's been the mission of now Baylor Scott and White. And so we have been and still are very confessionally a Christian ministry of healing. At the same time, we embrace the opportunity of serving those of all creeds and none. That applies to our patients, that applies to our caregivers, that applies across the entirety of the organization. We have Jewish individuals that are part of even our governance, as well as our caregivers, Muslims, Hindus, those of no faith commitment at all. And so within the board context, there's always been a seat for somebody who would come in as kind of a theological ethicist, somebody who would help Baylor navigate medical ethics issues within a Christian worldview that at the same time was in dialogue with other creeds, other expressions, other ways of thinking as well, rather than being so doctrinaire and so insistent on one point of view as to be violating our mission. So there was, for a very long time, a very dear friend of mine, Dr. Bill Pinson, who had been an ethicist himself, a PhD in ethics, who was in that chair. So Bill was rotating off the board after a very long period of time, and that's when Joel thought of me as coming on the board and serving in that kind of unofficial capacity. And then when we merged with Scott and White, board service at that point became a full-time job. To be on that larger Baylor Scott and White board, I did not have the margin to be able to serve in that capacity. So that's when Joel asked if I would take an official position as resident scholar for ethics. And I've been in that role now for the last several years, functioning in that part-time capacity as opposed to a full-time board, as would have been the case otherwise.
So arising out of that is an opportunity for me to describe two fun facts, one of which you know and one of which you may not know, that I write about in my book, The 60% Solution, that's coming out soon. And the first of those is that we've been talking about healthcare as a nation, if you can believe this, since John Adams. Mm. So John Adams actually imposed a tax on sailors because they were bringing back diseases when they had their transoceanic ship rides, if you will, or cruises or work. And he charged nickel, I think it was a nickel a month, which would have been a very expensive amount of insurance at the time. Mm-hmm. At the same time, what you do know, I'm certain, is that Baylor was actually the first to insure patients when they issued an insurance program for teachers in the city of Dallas. So is that still I know that Baylor may have 2 or 3 insurance companies, but do you recall?
When I was on the board, we were working within a self-insurance context, and that's part of why we were so interested in the merger with Scott and White, out of Temple, is that we believed that their system was superior to ours. We felt like they'd been able to get to a better cost reduction, to a better scope and scale, and we thought a combination would serve both sides of the merger more effectively, and that was one of the drivers behind all of that. And it is for the very reason that you're suggesting right now. We are missionally at Baylor Scott and White anyway, as a not-for-profit, a ministry of healing driven to care for those not only of all creeds and none, but of all payment potential and none. About a third of our patients at Baylor University Medical Center can't pay. And so being able to provide insurance internally and a larger kind of socioeconomic safety net for those we seek to serve is really part of our mission.
So we're going to dive into this more in just a minute, but that statistic is really both important and gripping, that about a third of your patients can't pay. Mm-hmm. So I want to put that on the bulletin board for holding just a moment, and I want to come back to it. But one of the things that it seems to me is the case is that when we talk about health, what you're really talking about is serving somebody who is suffering. It's not really talked about often enough, in my view. I read a lot about primary care in the book, but it's not talked about often enough in terms of disease or healthcare problem prevention. And so the question becomes, if you think about it, when you're offering services to someone in need like that, it's a form of suffering. And the question then becomes, you know, is it moral to profit by a clinician rendering services to a patient? Is that a moral thing to do?
It's an enormously important question. It truly is, Todd. And by the way, you didn't ask me to say this, but having had a chance to read the book, I will tell you that it really is terrific. It's not only a terrific overview of this, but it's got some solutions and some ideas and premises for the future that I really do hope everybody in healthcare will look at. And even those just concerned, which should be all of us, about healthcare as well. It's also very, very, it's written in such a way that it's really accessible and extremely well done. And I'm really grateful you've done that. It's been a labor of love for you, and I'm grateful to you for doing it. And as you know, a lot of what motivated you was this conversation that we're describing right now. I have a very dear friend down at Baylor University Medical Center, Chief of Pathology, who has for years said, look, we're not really in the healthcare business. We're in the disease care business. What we need to get into is the healthcare business. It's the old 80-20. I was shocked when I came on the board, the degree to which this is true, that we spend 80% of our resources on 20% of our patients and 80% of those resources on 20% of those patients. And if we could ever get out of the disease treatment to get back behind that and be more proactive, be in a preventive model, that's where we have to go. And we're attempting very intentionally to do this with accountable care organizations, with the kind of technology available to us right now, with patient monitoring, with patient diagnosis, with all sorts of ways that we can help disease before it gets worse. We can help patients before they become worse. All of that's behind us. So that has to be part of the conversation. But really, to your point, all of that aside, there's still probably going to be a case that we're never going to be so good at preventative care that people are not going to get sick and need treatment as sick individuals. Is it fair to profit from their sickness? Is it ethical when they really have no option? They've got to go someplace. They've got to get surgery someplace. They've got to get chemo from somebody. And so we all have this kind of opportunity, it seems, to take advantage of the suffering in which they find themselves. Is that a moral thing to do? Well, the other side of the question is it possible to provide such care for such individuals without the financial means that make it possible to provide that care? And so is it moral to come along and enact a world in which healthcare providers are not able to profit from delivering healthcare and therefore not able to be in the business of healthcare, and therefore there be no care for the suffering individual? Is the other side of the moral question. And there are ways really, I think, to kind of parse both sides of that discussion and try to get to a commonality where we can get to some place that's both fair for the provider and for the patient. That needs to be, I think, the place we try to drive.
There's a gentleman out there named Mr. Thompson, and I don't want to mess up on his name, but he's a radio personality. He's a fairly progressive thinker in the contemporary use of the term. And he has asserted that profiting from the rendering of services is immoral. I think that leads to a contention that we should have a single payer system and government rendered care.
Right.
And I struggle with that argument. I can understand how the argument might be made, but what to me it does is it discourages innovation. It discourages the quality of care issue. It discourages the evolution of care protocols. Is that your experience? I'm sure you had these conversations at the board level, and without betraying any confidences, how did you guys come out on that?
First of all, we're where you are at that point. If you go to single payer, you're essentially going to something like a Canadian system, and the Canadian system is a two-tiered system. There's a basic level of care provided on the single payer government model, but if you want more than that, if you want a knee replacement faster than 6 months, if you want a kind of chemotherapy that they won't offer, you just cross the border, you go down to the United States, or you have concierge medicine. You have a concierge experience that you're paying for. It'd be as though you're paying for private school, but your taxes are supporting public school. It's that kind of a model. If we ever get to a single payer model, that is what will happen. That's inevitably what will happen. If you take financial incentive out of the system, as we learned in Russia, as we see in communist Cuba, where I've been 10 times over the years, when there is no financial incentive It's very, very difficult in human nature being what it is to incentivize growth, to incentivize progress, to incentivize competition, to incentivize the kind of innovation that's essential to continuing the evolution of better and better healthcare. It's a drastic mistake to remove that incentive entirely from the system, I believe.